Okay, so we start. So this is most of the on-call cases for the GI system. And then just for your ear to take something maybe not to the, nuclear medicine, not only cases, and then you have to protocol that. So the goal just the basic knowledge of GI scintigraphy. Objective, know the basic things, radiopharmaceutical, procedure mining, knowing the indications of the scan, recognize abnormal finding. So this is all the including, but don't worry, we only go the first two today because that's the most ER cases. So what does a HIDA stand for? Daniel?
Oh, I forgot.
Anybody? Roberto? What's an IDA? It's a tracer. Yeah, that's a, just say, Yeah, that's the category of the tracer we use. Aminoacetic acid. Hepatobiliary. Because they may ask you, especially intern or the, what's a HIDA stand for? And new resident will ask me, okay, look for the paper. I cannot pronounce. But that's the tracer, the category tracer we use. Okay. So right now, Daniel, you are on call. I'm the physician in the ER. So I call you. I said, Daniel, I want to order the GI bleeding study.
Well, I'm going to want to know if the patient's NPO, when his last food, did he get any morphine?
Maybe later. You eat first, later.
No, I thought I hit it.
You already start. You want to finish? Okay.
Yeah.
So you want to know why the patient NPO and what else?
Any pain medications recently, just to
Okay.
control that sphincter voting, or
Okay.
yeah.
Okay, and then what else?
Um,
So if I say patient eat like 1 hour ago, what do you want me to tell you?
it needs to be longer.
How long?
6. I thought it was 6, maybe 4.
4 hours.
4 hours.
Ideally 4 hours. If really urgent, 2 hours probably okay. And don't eat that yet. Just finish it. And then if I tell you, Daniel, say patient cannot eat for last 3 days.
Wait, what's that?
Patient cannot eat. Did not eat for last 3 days because he's
Okay,
pain,
well,
vomiting.
No. Then there's also a problem with that, because it needs to be like the patient's eaten within the past 24 hours. I forget the reason why. I think because the gallbladder is too distended.
Okay, and then what do you want to do?
You give a hormone that I can't remember.
Hormone. So
CCK.
CCK. Okay.
Yeah.
So you need to tell technologies the patient haven't eaten over 24 hours, and then you need to do CCK pre-treatment. And then you give CCK, wait for 30 minutes, and then you do tracer injection. So that's all things you need to know. And then if patient on the morphine, how long do you want to get off of morphine, or you want to wait?
I can't remember the half-life.
Yeah, so, that's usually the standard recommendation say 10 half-life longer. I never use that. The book said morphine probably 6 hours. Most of the time I said 4 hours probably okay. We never had trouble, but if based on book I can say 6 hours, you hold the morphine. So that's you. And after you ask, and so what's the first thing you want to ask? You say, I want to hide the study. First thing you really want to know.
Is there any prior imaging?
No prior image. No. It could be. So why do you want to know the prior image? What's that related?
I mean, is there an ultrasound already?
What do you want to know on the ultrasound?
Is there a gallbladder?
Yeah. So that's the first thing you want to know. Because HIDA study could be for gallbladder, check up gallbladder, or could be for bile leak. And then, so that's a different thing. And then if say patient, I said, okay, patient don't have gallbladder. And then patient just eat and had morphine. And then what do you want to tell me?
The morphine can affect the sphincter, but
patient doesn't have gallbladder.
Right, so that's what I'm saying.
And
So-
then, can I do study right now?
No, because we're still gonna have to wait on the opiates, like morphine.
Okay, so the question is, probably not that matter. You see the leak, yeah. So if you don't have gallbladder, you are now working on the gallbladder, no preparation. Just go ahead to do that. Yeah, so that's the ER case. And so you already answered two major questions, so you can eat right now. So first question, need to know patient have gallbladder because not an uncommon patient come here, work for gallbladder, and they already no gallbladder. And then you wait and you do this, that, and then finally say, I don't have gallbladder. And then need to know NPO, ideally 4 hours, over 24 hours, and need a CCK pre-treatment, and need to hold a narcotic medication while they go over there. The last thing you need to see, check the lab, see if a serum bilirubin very high, and then you need to warn the clinician, say, we may not say gallbladder because the patient's liver function is so poor, and then, but they do not have a hard cut-off line. Say, definitely 20, I cannot do whatever, because it's really based on the duration. If they very chronic, they may already have some complementary of the liver function left. So you may still not say, you may still say. Otherwise, just depends. But you need to tell the clinician. Don't let them expect to say something and then after you work out several hours, tell them nothing. I cannot tell you anything. Okay, so indications of the HIDA study. Give me 3, 4, and do what you can do. Okay. Bile leak. Okay. Yeah, that's one kind of a bile leak. Yeah, but what else? But that's 2 major ER cases. And then of course you have a CBD, whether it's obstruction, sometimes you can use that, and then chronic cholecystitis. So what is a radiopharmaceutical for hepatobiliary image? We already mentioned that's in this category. Can you name one of them? So you tell technologists this trees I want. You have to tell technologists. What kind of tracer you want?
99M condition.
Of what? That's an isotope. When we say tracer, you have to give me the whole name. 90% nuclear biopsy study labeled by technician 99M. If you say that, I don't know what I'm using. You have to tell me what kind of a tracer. Yeah, do you know? Cholecystitis. Yeah, that brand name. Yeah. So basically, yeah, we use these 2. One of them should be okay. The top one, cholecystitis or microfining, it's a better one. And then right now, that's currently we are using. But occasionally, if it's like, okay, the pharmacy don't have this, can we use the second one? Yes, you can use second one. But if a patient has very bad liver function, and then you better to choose the first one. Oh, the small baby, you better choose the first one. It give you better results. And then the tracer mechanism is taken up by the hepatocytes and then excretion, just like a bilirubin, conjunctive bilirubin. And then this is an often question, maybe cousin for you also. When you report, you said, okay, I did not see gallbladder, I had a suggestive of acute cholecystitis, and then the clinician will ask you how sure you are. So that's this question. What is?
I remember the exact number, I'm pretty sure it's greater than 90,
Good. Yeah. So tell them, specificity is 90%. So they should be. So what's the sensitivity for acute Acakulous cholecystitis? Cousin, do you know? Or higher, lower? It's lower. Why? Do you know the reason?
This dollar is not moving, and it's not obstruction, it's just
Yeah.
poor functioning dollar.
Yeah, you're exactly right. They may not be due to obstruction. It's just due to gallbladder itself infection and then inflammatory. So the HIDA study for acute cholecystitis, the really things we are detecting is obstructive cystic duct, but not really direct say this is acute cholecystitis. Most time it is acute cystitis. So in this kind of situation, patient no stone, ICU patient, they may not have obstructive stone. So that's why the lower specificity. So we go the case. So this is our case. So maybe you do go to the iron. So this is the ER case, of course. When they finish the initial procedure, the universal, you do 60 minutes dynamic image. So after that, they call you, say, okay, this is the image. So what do you want me to do next?
So I can see the biliary ducts on the left and I see the gallbladder.
Okay. You don't think that this is the gallbladder? Okay. And what do you want to do?
So we can either wait 4 hours,
Okay.
do the scan like after 3 hours, which should be like 4 hours later.
Okay.
Or we can give morphine.
You can get more. Okay. So are you going to get the same result?
So with morphine, we can calculate the injection fraction later because we can do the 60K injection.
Okay.
And basically it should be the same results.
Good. So yeah, exactly. Yeah, she remember this very clear, very good. So you do not see gallbladder. You can do either you give morphine, or you do the delayed force image, and then the result should be exactly same. And then you give morphine. Usually ER case, of course, if patient can get morphine, you give morphine, and then you get result quicker. But the downside is, if you say this patient is a chronic cholecystitis, after morphine, you cannot give CCK to evaluate for ejection fraction because it's not accurate anymore. But you need to ask if a patient allergic to morphine or patient outpatient, drive by itself, and then you don't want to give them, and you don't want them to sleep on the rail. Very good. So, and then of course this technology did not show me. So they thought that this is a gallbladder when the Aya mentioned that's duodenum. That give you a lighter view. Very important, I show you. So they gave us CCK automatically. And then they finished study, turned in, they got 97% completely normal study. And then when they cross-brought, I realized, no, I don't think I saw gallbladder. And then this is just to give you the normal gallbladder position. And then this is the all cases. So lateral view, very important. Always look at lateral view. Because sometimes it can be very confused. They can overlapping with CBD. Or, you just confuse say that gallbladder or not. So this patient, you can say duodenum here, it's no gallbladder. This gallbladder should be really anterior. So I said, okay, call patient back with a second scan the following day. And then they still have some tracer left in the bowel. And then we again say this is a CBD duodenum. Lateral view, no gallbladder. And then we give morphine. Still no gallbladder show up. And then we report this cystic duct obstruction. And then patient went to surgery. So they find this cystic duct obstruction. It's a chronic cholecystitis. But so that's how you work out. If you miss the gallbladder, think that's a gallbladder, you completely made the wrong diagnosis. And then the next question, cousin. So when you do not see gallbladder, and then what's your differential? Okay. Okay. What else? So just like back to the first image when technology show you, and then you did not see gallbladder, and what's the question you want to ask the technologist before you make
Oh,
decision?
yeah.
Okay, patient, yeah, I have gallbladder. And what else you want to know?
Ask the technology.
Yeah. Or you ask the patient or ask the technologist. So you want to, so this is to tell you the differential, most common. You want to know, go back to the initial the preparation. A patient just eat or haven't eat for, right? So that's a,
Reiterate all the first questions.
yeah. And then make sure everything prepared correctly, and then you make decision. Yeah. So that's on your board. Could be ask you the same question, the differential, or they ask you what's the common cause for the non-visualization of gallbladder. It's not only cystic duct obstruction. Any eating probably the most common situation. They just eat or not eat or give morphine, all of those can demonstrate non-visualization of gallbladder. So go back to the prior case, they did surgery, they found cystic duct obstruction. Okay. So the next question, what is the mechanism of morphine to do when we do this? Why we use morphine? What do they do?
Practice feature ability.
How, why you are right, but why we did that?
Oh, so it causes the back pressure to fill up the cystic duct and to open it up and to fill the gallbladder.
Yeah.
Like that, instead of it just passing straight through the tongue valve.
Good. So that's why you need to give morphine to confirm, and then you close the downstream and then increase the pressure, let tracer back to the cystic duct and go to the gallbladder. So the dose, usually just 3 milligram. For your test, you may need to know this 0.04 milligram per kilogram. You can calculate. But generally, 3 milligram probably okay. Okay, Aya, what do you want to tell clinician about this? You want to rule out acute cholecystitis? HIDA study. Okay. Okay. Right have quadrant pain, has gallbladder, eat correctly, 4 hours NPO, no morphine prior, everything is correct. Correct preparation. Delay image is still nothing. And then what do you want to tell clinician? What's wrong in this image? You said you do not see gallbladder. What's other thing? You see kidney. Do you usually see that clear kidney? Do you see liver? Why? So that's something wrong, right? Because normally you should see very uniform, quick uptake in the liver. And then you may see a little bit tracer in the kidney, but not like this. This is like a kidney scan. Yeah, so why? What do you want to know? Yeah. So that's I give you an example. When the bilirubin very high, this patient 19, and then you do not see, the liver no function, enough function to excrete a tracer. Of course, you will not see gallbladder, but doesn't mean it's an obstructed cystic duct. So that's why you need at the beginning you need to warn clinician. We may not be able to tell you because your liver. Go ahead.
They're ordering a study and we're looking up the labs and stuff, and we see that all their liver function is terrible. Can we just tell them this is not recommended?
Yeah.
It's not going to be
Yeah.
very study is
Yeah.
probably not gonna work.
But they may still say, no, I still want anyway. But that's that issue, when they make a mind. But if you don't tell them, and then after 4 hours, and then you tell them, I cannot tell anything. They say, why do not tell me in front? You're wasting my time. Right? That's a different story. So this is this patient's CT, and then the ultrasound. They already suspicious some liver problem. So. Okay, Daniel, back to you. HIDA study.
All right, so we're seeing the liver fairly clearly. You're saying there's an elevated liver LFT and acute onset upper abdominal pain. I don't see any tracer within the CBD. I don't see any tracer within the blood or in the intestines.
So we did a delay image, exactly same image.
Okay, so
What do you want to
I'm
tell
thinking
me?
of an obstruction somewhere. I don't know what's causing it yet.
Where?
In the CBD or,
Yeah.
somewhere. Well, actually not even in the CBD because that I would think would fill up the gallbladder. So I'm thinking probably higher than the CBD in the hepatic gut.
Probably in the CBD because your pressure very high, the
Okay.
tracer cannot excretion at all.
Okay.
Even, they will not fill in gallbladder because you even did not say intrahepatic duct.
It would be the same pattern of cystic obstruction as well, right? It would be the same
Cys-
pattern.
no, cystic duct, you
It's
see
just
the
cystic
CBD,
pancreatic.
you see the intrahepatic duct, right? Everything normal except no
Except-
gallbladder.
Okay.
This one, you do not say anything, just very bright liver. So something got me. So this is the ultrasound. You see the stone in the CBD, and then they did the surgery. And then that's that's exactly ER case. I was a fellow. They call me in the middle of night and say, "What do you think?" 2 a.m. At that time, I don't know. I think it's obstruction, but I'm not sure. But of course, when you know that, This. Okay, next case,
And on that, sorry.
Go ahead.
On that previous case
Mm-hmm.
with what did we tell them to do on call? I understand that, we called you.
That's CBD obstruction, so they can,
ERCP, MRCP.
they can do ERCP, or they can do the angiogram, or they can maybe ultrasound even maybe help them. This depends on how urgent, how, what do they want to treat patient. Bottom line, they need to treat patient.
Okay,
Called GI.
gotcha.
That's even simple. Okay.
So I see explanation with this in the liver, but I don't see the ducts. I don't see the.
Oh, I already gave you an answer. But that's
Go with
fine.
biliary atresia.
Yeah.
So.
So.
It is biliary atresia, but you have.
Yeah, so I just want to show you this is exactly the same as the CBD obstruction. So the history, age, everything. But just no excretion in the biliary tract.
I won't see the liver. That's right.
You won't say what liver?
With hepatitis, I won't see the liver.
Hepatitis, you will see very poor liver uptake, not like this. But when you do delayed image, by the 24, so this is a need to make diagnosis based on the 24 hours image. You did not see here, you definitely need 24 hours image, and then you still not see activity in the bowel, and then you make diagnosis. But the hepatitis, you see poor liver uptake, and then by the delay image, you will see activity in the bowel. So that's the difference.
In the event, John, if you were to do this scan, I think what she was asking, if the liver was poor uptake from the get-go, do you already know your diagnosis? You can pretty much say it's DNA.
It is little bit subjective,
Okay.
so I still want to see the activity in the bowel.
And what scan do we give, not phenobarbital?
So this is your question. Yeah, that's exactly the on weekend they want to order, and then they call your guys and say, we want to order HIDA study for biliary atresia on Monday,
Okay,
and
so
then
an answer on this one.
yeah.
So good.
And what do you want to tell them?
It's gonna take about 24 hours or so before we got the study. Is that what you mean?
No. So what kind of thing you use? Just you ask a question. What kind of thing you use to increase the
We're trying
sensitivity?
to get
You already answered.
yeah, right, but we're trying to get the enzyme activated.
Okay, what kind of thing make that increase? You already said that phenobarbital, right?
I was trying to tell you.
Well, yeah, it's all, but the enzyme that act,
Cytochrome P450.
that I kind of remember.
What? Cytochrome P450. All of the liver functions are P450.
Oh, okay, gotcha.
Yeah. So you tell them, it's better you do pre-treatment with phenobarbital 5 days prior study. The issue is if you don't do this, sometimes they don't want to do, but that's fine. It depends on them. This is our recommendation because the issue is if they have lower suspicions, probably okay. You do this without the activity in the bowel, it's done. But if they have a high suspicions and then we do not see activity within the bowel at 24 hours, and then we have to say, okay, you did not do pre-treatment, and then we are not sure because just maybe the liver not mature, function not mature, and then you better go back to do that again. So we have a case like that, and then they go back to do pre-treatment, and then they have to come back to redo the study, and then finally we saw the activity within the bowel.
So it's indicated in all infants?
Yeah, all of the baby they suspicion for biliary filtration.
Oh, so you give it every time.
Yeah, every time we give them recommendation. Yeah, all of if they want to, they suspicion for biliary filtration. And then you just tell them, if a study turn out normal, no problem, no doubt. And then if study turn to be positive and suspicion for biliary filtration, and then you have to go back to do this again because that study is indefinite.
Okay.
So this is already Daniel already answered early on for bile leak, no preparation, and then the order go do that. Okay, this is our ER case. Ms. Cousin, is that your turn? What do you want to tell clinician? Patient had a cystic, cholecystectomy.
I was going to say, oh, sorry.
Yeah.
So you're looking for a bile leak there?
Yes.
And I'm suspecting, based on that, it's leaking.
Okay. Yeah, so they have bile leak. But the question is where the leak from?
Looks like it's from the left. Okay.
Left.
Right, I mean, sorry, going over the right, the left.
So this is a really question. They sit down there, say, you have to tell me where, and I can do, and based on that, I can do something, right? So
This one is the right side.
right side.
Going to the down. You can see it further on the CT.
So what's the exact location they come from? Let me see if we have one. So the trick you see is run that Sydney one by one. So this is Sydney one by one. Look at the first abnormal side. That's the first, and then you follow that. You see they become larger and larger.
Down to base and see if we can. I thought, looking at it over here, I thought that was just part of the drawing.
Yeah, so when you see here, and then you get confused. So that's the trigger. No matter it's a leak or bleeding, follow the series. Look at the first point where they come from. So this is in the cystic duct, the remnant of the cystic duct. Yeah. So if you come
So
out,
that's at the level of the
yeah. At that time, we don't have a spec CT, but this is CT, and then you can see the surgical clips here. And then that's the way you exactly tell. It's here. You see, this is the intra-left hepatic duct, and then this is probably middle, and then they're going down CBD, and then this is cystic duct here, and then this is gallbladder, expected gallbladder. So they take this gallbladder off, and then they not clip this very well. And then they, based on this, they go to the ERCP, and then they injection, see the flush here, and then they put a clip, and then resolve. So that's this case. It just magnify to see that. Okay, who's continuing? Oh, your turn. Doesn't matter. That's all ER case. So that's a patient who came with a trauma, 16 years old, male. CT shows some laceration, fluid around the gallbladder fossa, and then they want to know whether the patient have a leak.
So there's always that abdominal relation, 10-minute mark. You see on the right, you can see what I'm assuming adds up to that laceration in the center, approximately Acakulous.
This is the center.
Yes.
So this is laceration location. So have decreased uptake. Okay.
You can still see decent washout with it traveling through this bile duct.
Common bile duct. Which one common?
I
So.
mean, it's obviously leaking now.
Okay, so it's a leak. And then, of course, that question is then you need to tell me where. Where the leak. And then, based on where the leak, and then you know the leak type. And then, based on that, you decided what kind of surgery you do. Can you tell where the leak?
I mean, maybe in segment 4, but I'm not, it looks like it could be more than one spot.
So, it's again, when you get this cine image, you know the leak is eventually going into the abdomen everywhere.
Yes.
And then you need to follow this again. Where is it? So this is probably right, left intrahepatic duct.
Yes.
And then you go here, and then what's this?
It says leaking from the left.
Yeah, so this is the leak tract. And then they go from this left intrahepatic duct and connect this abnormal tracer focus, and then eventually they spread into the abdomen. So that's so we told them.
How much longer after, I mean, do we have about time frame?
This is the always universal patient come to do 60 minutes dynamic image. So this is 60 minutes. Of course, this is a screenshot. Technologists just fuse 10 frame. So this is tell you 10 minutes, 20 minutes. But when you really look at the reading station, you will see 60 frame. They can fuse whatever they want, but you know that's 60 minutes. This cine is just around 60 minutes. So the trick when you initially when you start on call, especially have leukemia study, don't let technologists go. You tell them immediately call you and wait for you to come down to look at that, because you may have difficulty to display on the screen, and then so you can let them help you. So this is in the middle of night. They call me like 1 a.m. and then fortunately technologist is still in the hospital. So I let her use the FaceTime on the cell phone, and then show me that name so I can make diagnosis. Otherwise, because they are waiting for the go to the surgery.
That's the key. So Dr. Young is on call for PubMed probably 90% of the year. And
So we probably will change that. I'm thinking about changing that.
she wants to be 95% of the time. She's going to drop down to 85%. But I mean, regardless, if Dr. Young's on call, what she'd like you to do is if you're going to ask her for help, call Dr. Young, get a hold of her before the tech leaves. Because Dr. Young has already instructed the techs, show me this image,
show me this sequence, and they know exactly what to show her so that she can help you out with making the call overnight.
Yeah, because if I log in on PACS or whatever, right now I cannot log on anyway. But if I log on, those it not support those images, so it won't give me any information. And then, so just let them, but don't wait too long. Just let them wait like a middle of night, like technology wait half hour, 1 hour. So it's really just if you can, just come down immediately so they can help you. And then, so this is all of those give you a mark. Of course, this we publish this. Sandra left, she wrote this, and then we got onto this cover page. We really like this image. So they did the ERCP right after that, and then they confirmed that's the leak track, and then abnormal focal tracer accumulation, and then they did the surgery, and then this is the first case I saw, really that clear to direct where they come from. Of course, when you see once, and then you know that you can see, you will search for, you will see more and more cases. You exactly tell them where they come from. So for this case, they did a minimally invasive treatment. They drain light and then put a CBD stent. If a patient have really diffused, and then they have to do resection. So that's the type. I'm not going to go over there, but just let you know, based on the leak location, you know what kind of type of leak. And then certain based on that to decide what kind of surgery they will do. Whose turn? Aya. What do you want to do? So this is probably bound. I will say this is something around the gallbladder fossa. Yeah, I couldn't make this work. So this is this. It's anything else? This is 1 hour. What do you suspect right now? Mm-hmm. Why you want to do 4 hours? Okay, so that's the issue. The time it's your friend. Especially nuclear thing, you check for physiological thing. You need to give time. So if that too small leak like this, you think that's a leak, but you are not sure. And what do? They need definitely diagnosis. So you need to do delay. And then for the so in fact it's here and also here. That could be reflux from duodenum to the abdomen, but you need to confirm that. And then they did a 5-hour delay, and then you can see the persistent activity get progressive accumulation in these 2 locations. At that time, we don't have a spec CT, and then so you can turn patient different position, see that change, or let patient drink something. Yeah, go ahead.
Without the gallbladder, what do we give when you got to go to water?
No, we want to say that's in the GI tract. If you let them drink, you wash them, and then still stay there, and then you confirm that's not in the GI tract. So this is that's the CT. Yeah, so this is biloma. Biloma, a lot of time you will not see clearly in the early image, or you even not see, you see cold area. So the standard protocol for the leak, we do the initial image, we do 4 hours delay and 24 hours delay, because you try to catch up the small leak. And then you also, if you do delayed, your more tracer clean up from the liver, your small leak will show up. Sometimes just a tiny leak. We have the cases just a couple weeks ago. It's a very small leak. And then So this is so this is a similar case. I just go over that. This is our case. We had a SPECT CT. We did the initial imaging. Of course, the patient had cholecystectomy. And then you look for the abnormal. You always just raise question. You may not make diagnosis, but something should be not like that. Intra-left hepatic duct is too much. And then this one look like gallbladder, but patient don't have gallbladder. So and then you have to question what's that. And then probably leak, could be biloma, so do delay. At this time, if you do SPECT CT, you might be able to see with the SPECT CT. But anyway, we did delay the imaging, so we see this area get larger, this is get larger. And then we did the SPECT CT, and then you see this is exactly fused in this fluid collection. So this is a biloma. That's an MR later on, and then they dream that. Okay, Daniel, new case. So patient had surgery, nephrectomy, and then during surgery saw some liver injury, small injury they did not repair. And then after surgery they did the CT scan to rule out for biloma or bile leak.
I got 4 axis cuts. The level is very full of the kidney.
Right kidney, they did the right nephrectomy. Non-contrast.
Yes.
Is there anything you're suspicious of?
Yeah, I mean, there's a specific fluid collection, throughout that whole area.
Okay. So can you tell what's this contain?
Was that cooling?
Yeah. What's this? So give you differential.
I mean, is that air in there?
No, no. Just I
I'm
think
gonna
just
go
one
with,
day, 3 days. This is sufficient for bile leak. Can you
Yeah,
rule out a
it
bile
could be-
leak?
It could be.
Could be a bile leak, right? Could be a biloma. What do you want to do to say it is yes or not? Confirm that. Do a HIDA study. Okay, so this is a HIDA study. So you see this location,
Yes.
and then this is a nuclear thing. This is a fusion image. So how do you think right now? So this is a cursor. When you click that, exactly they will fuse in the same location.
I mean, looks like it communicates. I mean, we've got.
Is that bile leak?
Within the fluid collection, that drives from the inferior aspect of the liver.
So this is a location, and then you follow that. What's this look like?
That looks like a little bowel.
Yeah. So that's loops are bile, no bile leak.
Oh.
That's a. This is different. That's the chronal view, and then of course when you see all the loops are bile. When you're on the SPECT CT image, you play them, and then you follow that. You follow the thing. You use the cursor, go here, and then you exactly trace the loops are bile. So that's no bile leak. Very powerful thing because people cannot get contrast, and then they do see liver injury during surgery. They do suspicion something, and then you saw this thing, and then do HIDA study very easy, and then you tell them no bile leak. Okay, GI bleeding is another common study they will order. Of course, the poster. Yeah. So they call you, say, I want a GI bleeding study. What do you want to know before you say yes or?
Well, I want the patient to be stable first, and then I want the patient to be actively bleeding.
Okay.
And
How can you tell the active?
just having written for now I have
Okay. What else you want to know?
Do you care about last week?
What's that?
Do you care about the last week?
If I don't understand, we don't care. Cousin.
want to know the H&H and the blood pressure.
What's that related to?
Well, if the blood pressure is too low, it's not gonna, maybe it might stop the going on, whatever study. Not to mention stability of the patient.
Okay, what's the first most important thing you want to know? Not really. It's not stable if they want to know, you have to do anything. So the first thing you want to know, what's this study really for? For upper GI bleeding or the lower GI bleeding?
Oh, upper GI.
Yeah. So that's the first thing you want to know. Do you suspicious this patient have an upper GI or lower GI? Right? And then because the upper GI study, it's not indication for this study. And then you will stuck over there. When you look at study, you have no idea. So, but for the clinician, they are very easy to rule out upper GI versus GI. But if they said, okay, we don't know, patient just got ER, we haven't seen the patient, patient say have some blood, we don't know upper or lower. And then what do you tell them to do to rule out upper GI bleeding in the ER?
So rule out an upper?
Yeah. Very simple thing. GI doctor is not in the hospital. Is there anything else? Is there anything else they can do to rule out?
Put a tube in?
Yeah. To NG tube. 5 minutes take them to do that. Immediately rule out upper GI bleeding study. Instead of they come here, they do like several hours, and later on say, I'm not sure is that upper or lower GI. It's a bleeding or technique issue. So that's the first thing you need to know. And second thing you need to know, like Aya said, is this current bleeding, it's now bleeding. And then if not, we are not going to count up. Patient 1 hour's bleeding, go bleeding, we are not going to say. We have to count up the bleeding during our scan. And then you want to know if patient has a blood transfusion because they report they may interfere in the study. So if you say yes, and then tell them either you finish this, to do this study after you finish transfusion, or you plan to do and wait for us to finish our study and then transfuse. So that's probably 3 major things you want to know, and then basically.
So after the transfusion or before they start the transfusion?
Yeah. So it's again primary indication for lower GI bleeding. So we try to local. And another thing they call middle of night, and then you probably, if during daytime it's okay, but they want to order, like a 12 o'clock or 1 a.m. And then the question, what do you want to do at that time? I mean, they don't want to do anything, and then really no point you do this. This is not treatment. This is diagnostic. And then if they say, oh, we want to immediately go to IR, is IR people available at that time? So there's a lot of issues, so we could try to discuss them. But if say weekend, like a morning, afternoon, yeah, no point. We just go ahead to do that. Don't argue too much.
So GI bleeding lower is indication?
Yes, not for upper GI bleeding. If they said this is with suspicious upper GI bleeding, they should go to EGD. Not for this study. I will show you why.
This is a different study?
No, the same thing.
GI bleeding study. Yeah, this study is usually cannot diagnosis for upper GI bleeding. So whether they have a current bleeding or not is not based on they have a blood. It's just past blood is due. That's no definitely correlation. They can't have bleeding 2 hours ago or 2 days ago. They just have bowel movement right now. Then they say blood is due. That then indicate patient have current bleeding. And then this is the 3 signs indicate patient have current bleeding. But usually very difficult you say that condition. But I'm just letting you know this is a hypotension, increase the heart rate, and then decrease the urine output. That means the patient has current bleeding. So what's the bleeding rate? That's GI bleeding study detect. Daniel?
Gram over 12.
So 0.1 cc per minute.
Let me calculate that.
What's the angiogram detect rate?
5cc.
0.5. So that's all study much more sensitive. So it's not uncommon. All study positive and then IR is negative. So we already mentioned this. Put NG tube. Or do the EGD. Of course, the most usually they just came so busy. They haven't seen the patient. They don't know anything. They just come to do this very expensive and time-consuming study. That's why you need to, especially at this time, you are new. They are new also. So a lot of new residents. So transfusion, we said don't do that. And then 3 methods. So we run, we have a little bit of time. So I just go over this. But remember, this will show on your test. So we use the tracer technician labeled RBC for this GI bleeding study. We have 3 methods to label RBC. And then we have an in vitro. With the higher efficiency, you withdraw the patient's blood and then put it into the mixture with the cold case and the isotope. And then you re-inject back. So this has a higher efficiency. So this is for GI bleeding study. And then we have in vivo, and then you label within patient's body. It's a very lower labeling efficiency. This cannot use for GI bleeding study. You can use this for marker study. We have modified either in vivo, in vitro, kind of in the between. Nobody really use that, but just know the term for your test. So when you do tracer, again, tracer 2 portion. One is isotope, technetium 99 isotope, and always label something. For this case, GI bleeding study, you label with RBC. And then for other study, MDP for bones, again, omega-3, whatever, you label that. So when you label them, after that, they always have 3 different components in that mixture, the tracer. So one is the desired thing we want, that's a tracer. Isotope ligated to the chemical parts. And then another thing is they may have some portion they are not ligated together. And then that's a free, we call free tag on this GI bleeding study. Just say the technetium separated from the RBC. Or something they ligated and then they hydrolyzed. So this is a 2 form we don't want. And most common we will see this thing. And then this free tag, we call free tag, they go to stomach, thyroid, salivary gland. That's why, because they go to stomach, no matter how good you label them, they always have something left behind, like free tag. That's why this study is not for GI bleeding study. Because they have this free tag, they will go to stomach and then we will get confused. We don't know that due to free tag or the bleeding. So, who's the cousin? GI bleeding study. What did you see? This one?
That's the gastrointestinal.
Yeah, in the stomach. That's what I mean, yeah. Okay.
Is that not the bright spot at the top? Is that still our signal at the top?
This one. This is probably the spleen, liver,
Oh, the spleen. Well,
and then
I don't
heart.
see anything coming out of the
Okay.
stomach, but it's not progressive.
What do you think? What do you want to tell them? Negative for bleeding. But why they go to stomach, the tracer? Do they normally go to stomach?
They inject free.
Yeah. So this is a free tag. And then you free tag, the feature is, they show stomach almost at the same time. They see the contour, outline the stomach. And then, so this is likely to be free tag. This is a very typical case, easy to see. Sometimes they may not. and then you will get trouble. That's why it's not for object bleeding study. And then this is all case here again, you see. And then sometimes they can flow down. And then you will say, oh, that's the gastric bleeding or duodenal bleeding or, or free tag. So this patient very hard to stake. So after that, the manipulate everything and then have a very poor labeling efficiency. So if you're suspicious that free tag, what do you like technologists do? Is that I want to say that maybe free tag. Can you do something to help me to?
Some delayed images to see if it all goes away.
What else? Not delay image. Delay image probably not help. Some additional image you can. We said the free tag go to salivary gland, thyroid. Yeah. So you want to see whether.
Get a big scalp view of all of it?
Yes. You want the scar in the high neck, and then you see so many things in the salivary gland, and then thyroid, so you know there must be free tag. And then this is just magnify that everything. But on your board, they may show you another image like this, and then you see a lot of tracer in the brain. This is you see free tag, it's in the scalp, but they are not going into the brain. This is go to the brain. So this is an MA study with right to left shunt. They may show you a picture on your exam so you know what's going on here. And then this is a whole body free tag. And then free tag you can use like a micro scan. And then sometimes you do whole body scan, you can see that. And then you need to know the procedure, tell the clinician the time range. So generally we do 90 minutes. So patient have to be bleeding during 90 minutes, we can cut up. And then if patient don't have bleeding, we continue 90 minutes. And then if patient has bleeding, tell technologist if you saw bleeding at any time, immediately call you. And then you come down, look at, confirm. You can confirm that's a small bowel, large bowel. When you know that, you can stop right away. And then you can do SPECT CT or you can send patient to. You can do the SPECT CT. So then you where the bleeding from? So I tell you those are bleeding. You see they flow.
Yeah.
Antegrade, retrograde. The large bowel, small bowel.
I'm gonna say it's gastric. It looks like it's going down to duodenum and up to ligamentrites. I could be completely wrong. I'm gonna say small bowel right now, or it could be the transverse colon.
Where? Say the location. Which one you prefer? This is the abdomen, right? Here. You think a large bowel, small bowel. In the peripheral.
I'm gonna go colon.
Yeah. So that's a colon location. So this is just, you see some extravasation and then you follow them and see either antegrade or retrograde. And then when you see this, they are moving, that's a best sign, bleeding, got to be. Sometimes it was too small, but I never saw that. Just see something looks like abnormal, but they never move, probably not bleeding. Like a prominent vessel or something else. Okay, sometimes tumor, metastasis, anything. But bleeding has to move. And then they, of course, they did angio, they saw this blush, and then, yes.
So when we did the free,
Mhm.
we see the stomach.
Mhm.
It's not gonna progress more.
Sometimes they can. That's why it's so confused. Yeah. So this case is all case, and then you saw here, and then after you see that, you need to do SPECT CT, correlated with the colon, ascending colon, and then you did not see mass anything, so this is like a curriculum, those things. And then we did the IR here, and then blush, and then clear, successful. Yeah, small bowel, large bowel bleeding here. Yeah, so this is how small bowel looks like curved. Yeah, curved. And in nature image, you can see the most important flow. You see something, you immediately know flow from bleeding from there. And then delayed, you can be confused if you don't count up the first point, and then you don't know where they come from. They already move all around. So that's why we always do the flow. Sometimes the quick bleeding, you can immediately count up. And then the next question, they said, can we do delay? Yeah, you can do delayed imaging because you negative study and then said we want to do delay. And then you delay image, you see something in the colon, ascending colon, you just say patient has bleeding in the interval, but you cannot tell where they come from because bleeding already flow everywhere. Okay, so this is a treatment. This is a problem.
Thank you, Dr. Yao.
Okay, thank you.